Thank you, Cassie, and good evening, everyone. I'm Robin Toohey, Senior Director of Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's teleconference on CAR T-cell therapy, what myeloma patients and caregivers need to know. Tonight's program is part of the IMF's Living Well with Myeloma teleconference series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. I'd like to thank our sponsors for their support for tonight's call, Amgen, Celgene, Janssen, and Takeda Oncology. If you've not yet downloaded the slides for tonight's teleconference, please go to myeloma.org and click the top bullet under New and Noteworthy, and you'll be able to access the slides there. I'd now like to introduce tonight's speakers. Dr. Abenauer from Indiana University Simon Cancer Center will provide an overview on immunotherapies, including newly approved daratumumab and elotuzumab, plus an introduction to CAR T immune therapy. Dr. Abenauer is a consultant for the IMF and is also part of the IMF's International Myeloma Working Group. Dr. Stadmauer is from Abraham Cancer Center, University of Pennsylvania, and is also part of the IMF's International Myeloma Working Group and will speak specifically on CAR T immune therapy. We're very pleased to have them present on our call this evening and to also field your questions at the end of this presentation. So remember, if you have a question, please press *1 on your phone keypad and we'll get to all questions at the end of this call. It is now my pleasure to turn tonight's teleconference over to Drs. Abenauer and Dr. Stadmauer. Thank you.
Well, good evening, everyone, and it's quite an honor to be presenting to you tonight with my colleague, Dr. Stadmauer. So my job is to talk about immunotherapy, so I'm on slide 2 here, which is the title, What is Immunotherapy? And basically it's using the immune system to help fight myeloma or mimic the immune system to help fight myeloma. So just to set the stage, immune system is really 2 parts. One we call the humoral immunity and one called cellular immunity. Humoral immunity using antibodies. So when you get vaccinated, you make antibodies to help, for example, eradicate influenza. So these are the antibodies. And antibodies actually can bind to cancer cells and kill them. So that's using antibodies to help fight cancer. The other part of the immune system is called cellular immunity. So basically the immune system is like the soldier, the Marines, they go and bind to the cancer cells and destroy it. So these are the cytotoxic lymphocyte and the natural killer cells. So in terms of antibodies-mediated immunotherapy, so basically what you do is you engineer antibodies that can recognize myeloma cells and kill them. So how do these engineer antibodies kill the myeloma cells? Either by sort of bringing something called complement, a special protein that destroys the myeloma cells, or bring cells that bind to the antibodies and kill the myeloma cells, like the cytotoxic lymphocyte or natural killer cells. On slide 4 is what you see how these antibodies work. Basically, they bind to the myeloma cells and bring the cytotoxic lymphocytes or activate complement or directly kill the myeloma cells. And you can see here there's a lot of different antibodies being used for these antibody-mediated cytotoxicity. So, for example, daratumumab can bring these effector cells to kill the myeloma. Daratumumab can bring the complement to destroy the myeloma cells, or even can directly kill it. But, for example, other drugs like the Elotuzumab depends on the immune system to kill the myeloma cells. And there are a lot of different molecules being used to directly, an antibody that directly kill the myeloma cells. So the 2 targets that are now being used to destroy myeloma cells using engineered antibodies are the CD38, that's on slide 5, and the SLAM F7, as you can see on slide 5. So if we go to the daratumumab, which is the monoclonal antibody that binds to CD38, This actually has been approved based on this study. On slide 6, what you can see, when you take this antibody alone in patients who have seen multiple line of therapy and have failed multiple line of therapy, you're getting a 31% response rate. Some of these responses are excellent, like, there are 3% complete remission or better. There is 13% of the patient got rid of 90% of their cancer, very good partial response. So this is a very encouraging antibody that mimic the immune system to eradicate myeloma, and now we are using it in combination with other drugs, for example, Velcade, where we get almost 60 to 70% response rate. So this is a very effective drug and is actually moving probably early in the management of the disease. And this is just to show you that when the patient responds to the treatment, has a prolonged survival, and it takes a longer time to relapse. That's slides 6 and 7. The overall survival looks very impressive. How about on slide 8, the Elotuzumab? So this is very important for people to recognize that this antibody, when it binds to the myeloma cells, it does bring the immune system, such as the natural killer cells, to try to eradicate the myeloma cells. So when this Elotuzumab was used as a single agent activity, wasn't very robust. But when used with other things, such as Revlimid, the response rate was much better. So on slide 10, it just described to you was Elotuzumab is a monoclonal antibody that binds to SLAM7, and on its own is not working well, but when you combine it with Revlimid, you get an excellent response rate. And this is the clinical trial that led to the approval of the drug, where Elotuzumab was combined with Lenalidomide or Revlimid, and that was compared to Revlimid Dexamethasone. That's slide 11. If you go to slide 12, you can see, for example, the progression-free survival. That means what is the median time it takes for the disease to come back and relapse. And you can see when you use Revlimid Dex, it was 14.9 months. If you add Elotuzumab, it takes 5 months on average longer to progress. And if you look at the overall response rate, how many people responded, had a reduction, destruction of myeloma, was 79% in the Elotuzumab arm versus 66% in the Revlimid Dex alone. And the number of patients getting very good partial response was 33% versus 28%. Again, this is a drug that brings on the immune system to try to eradicate the disease, and when you combine it with drugs such as Revlimid that also bring on and stimulate the immune system, you get better results. And again, this is a very important drug that is going to be probably moving early on in the management of the disease, and maybe after transplant, turn on the immune system to try to eradicate any residual disease and get to this condition called minimal residual disease, where you eradicate as much as you can of the disease. So let's move on to the cellular mediated immunotherapy. That is slide 13. So basically, there are two kinds of cellular mediated immune therapy. So you can say, well, how about waking up the patient's own immune system? How about we make the myeloma cells be recognized by the immune system and awaken the immune system? So these kind of drugs that does that, called checkpoint inhibitors. And these have been remarkable drugs in other cancer, for example, lung cancer, melanoma. You use these checkpoint inhibitors, you awaken the immune system, and you get a great response. The more sophisticated and sort of custom-made cellular therapy is what you're going to hear from my colleague, Dr. Ed Stadmauer. He will present to you more specific information about CAR T cells, but these are T cells that have been engineered to recognize specific marker on the myeloma cells and kills it. So the checkpoint inhibitor, there are what we call the old checkpoint inhibitor, and there's the newer checkpoint inhibitor. Actually, one of the classic drugs that we use in multiple myeloma is lenalidomide. So actually it does enhance what we call the checkpoint blockade and induce the destruction of myeloma cells by cytotoxic lymphocyte. So that's why lenalidomide has been a very important drug and has been used in managing patients. And when you use it in maintenance, it does prolong survival and delay relapse, probably because of this checkpoint inhibitions. The newer drugs that are now being used for and being explored in multiple myeloma are these called anti-PD-L1 and anti-PD-L1. So the first in class, this drug called pembrolizumab that have been used in other cancers with success, not approved yet in multiple myeloma, but there are tons of clinical trials ongoing, and especially using it in combination with lenalidomide to see if those combination can eradicate myeloma and probably achieve a minimal residual disease. So stay tuned for this combination of drugs. And I bet you that in the near future we'll probably get some kind of approval of these drugs in myeloma. So the CAR T cells, as I told you, is the cytotoxic lymphocyte on slide 15, recognizing the cancer cells and destroying it. You will hear more about it from Dr. Ed Stadmauer, so I'm not going to go through a lot of details, but I just show you on slide 16. It's not a very simple thing. You basically have to take the lymphocyte from the patients, genetically engineer them to recognize the myeloma and to have a killer proteins that will destroy. So this is a sophisticated, custom-made patient T cells that recognize myeloma. And the most important thing is really to know, okay, what is the target on the myeloma cells? Which antigen we should be targeting. Dr. Stadmauer is going to mention to you the, for example, CD19 antigen. So there's the flags on the surface of myeloma cells. There's the CD19, there's the CD38, the CD138, the SLAM7. So which antigen should we pick that is present on myeloma cells but not normal cells that we can attack and eradicate the disease? And that's really the most important thing to recognize, is that can we come up with an antigen that, for example, very successful. And then the slide on slide 17, for example, they use the B cell maturation antigen as a target. And this is a trial where on slide 18 you look at the design of the trial, you give combination of drugs, and you try to then give an increasing dose of immune cells and see what happened. And actually in this trial, there was one stringent complete remission. That's incredible. Very good partial response in one patient, and 2 patients had a partial response. So this is an early trial that using this specific antigen. So what are my conclusions? I would say that immunotherapy has come a long way. That's slide 20. Treatment with monoclonal antibody has resulted in remarkable results in even refractory patients. So when we move these monoclonal antibody early in the disease in a newly diagnosed patient, I bet you we will see remarkable results, and we'll see a lot of patients in complete remission and hopefully in lasting remission. I think checkpoint inhibitors are showing great promise and may lead to the eradication of residual myeloma, and I would bet that engineered T cells are very promising, and we will hear more about them from Dr. Stadmauer and others. So it's my pleasure to turn the microphone, if we say to speak, to Dr. Stadmauer to talk to you about his experience.
Thank you, Rafat, for such an excellent introduction to immunotherapy for myeloma. It's, the cornerstones of therapy for myeloma have, started off like the cornerstones of therapy for all cancers with radiation therapy, to plasmacytomas and areas of painful lesions, chemotherapy, classic cytotoxic chemotherapy, like cyclophosphamide and doxorubicin. Corticosteroids are, which is always the patient's favorite agents, such as dexamethasone and prednisone. And then now all of these explosion of really interesting modulations of the immune system. And the area that I'm going to spend the rest of the talk about is cellular immunotherapy for myeloma, using a person's own cells or potentially someone else's cells to attack the disease. The rationale for using cellular immunotherapy has been there for many years. As you know, these agents that I just talked about, chemotherapy and even high-dose chemotherapy and autologous transplant, have done wonders to extend survival for patients with myeloma, but progression remains ultimately common. We know from biology, and remember, all that we're talking about starts off with an idea and some basic laboratory research to understand things, and then we try it in the clinic. And we know that immune cells, the ones that Dr. Abanar was talking about, the T cells and the NK cells, can kill myeloma cells in the laboratory. And we also know that donor bone marrow transplant can cure myeloma by the infusion of a donor's T cells into a person with myeloma. The problem is that this allogeneic bone marrow transplant or donor bone marrow transplant tends to be associated with high morbidity and mortality, usually associated with that graft versus host disease, where the same cells that can attack the tumor can also attack you. So the whole concept of creating cellular immunotherapy is perhaps we could engineer our own immune cells to specifically attack myeloma so that we get the good graft versus myeloma effect without the bad graft versus host disease. So on slide 23, you can see the overview of cellular therapy in the clinic, and it's what Dr. Abanar has reviewed. Whenever you hear about cellular therapy, the first step is you have to collect the cells. And this is usually a procedure that's similar to the collection of hematopoietic stem cells from the blood. Usually you can stick one needle in one arm, one needle in the other arm, and for an hour or so collect just the lymphocytes or the T cells. Then outside the body, these T cells are manipulated to put on their surface warheads that will be directed against the tumor, in this case myeloma, and then they are cooked up so that you can get a volume of these cells. Meanwhile, the patient, and this takes about a week to 2 weeks nowadays to collect and to create the therapy, these engineered T cells. In the meantime, the patient has to have sort of an immune suppression or frequently get some chemotherapy to suppress their own lymphocytes so that when you squirt in these cells that have been engineered, they can grow rapidly and then attack the myeloma. Now, the actual engineering of these cells really is a major advance and a major acknowledgement of how basic science can really be translated into the clinic. In fact, my son is a senior in college right now, and he is a evolutionary biology major, so he majors in biology. And they actually used, during their first lecture of molecular biology, they actually used the CAR T-cell studies as an example of how what they're learning in the classroom is really bearing fruit in the clinic. And if you look at slide 24, it shows the three major biological advances that allowed us to do what we're doing. The first step is you have to be able to create a warhead for the that will be put onto a person's own T cells so that they will attack myeloma cells. And the name of the warhead is a chimeric antigen receptor. And what it has on it, it basically has outside, it goes through the whole cell. And at the top of it is a receptor that will latch on to something that's on the tumor cell. And in the case of the first study that we did with myeloma, it was anti-CD19. CD19 is a protein glob that's on the surface of some myeloma precursors. We also use that BCMA that I'll talk about in a second, and that Dr. Abinor also spoke about. In addition to having the warhead on the surface of the cell, going through the cell are these what we call signaling domains. And so these are sort of energized portions of the cell that, or of this receptor, so that when the receptor finds a myeloma cell, it activates the T cell to sort of eat it up, as well as to proliferate. So it actually it actually makes the T cells grow more and get more angry the more myeloma they see. So that was the first thing, and then and this is a protein, and so it's genetic. You use genetic material to make this protein, and so they create a gene, an artificial gene. And then on the left side of this slide, what the next thing they did was they inserted this gene for this chimeric antigen receptor into a virus, and the name of the virus is a lentivirus. And what we do is we actually infect the T cells that we take out with this lentivirus, and the lentivirus inserts the genetic material into the living T cell. And it's not a virus that infects people, fortunately, but it is a virus that inserts the genetic material. And then the final molecular biological thing that allows this to happen is on the right side of the slide, where we've created this artificial outside of the body sort of brewing system, sort of to allow outside the body for these cells to be stimulated and to proliferate. And in fact, it's an artificial cell that includes a magnetic bead that has on its surface these antibodies that stimulate these T cells to grow. So this whole process of infecting or taking out the T cells, infecting them with genetic material that will put on its surface the warheads, and then cooking them up, that whole process takes about 1 or 2 weeks. And then you infuse these cells into the patients with the disease. Now, the original CAR T cells, or the initial studies of CAR T cells, used this CD19-directed cells to treat what we call B-cell cancers, chronic lymphocytic leukemia, acute lymphocytic leukemia, non-Hodgkin's lymphoma. And as you can see on slide 25, there are now many clinical trials that have been published, in many different centers, that show in those diseases of chronic lymphocytic leukemia, acute lymphocytic leukemia, non-Hodgkin's lymphoma, maybe 50 to 80% of the patients who have relapsed and refractory and not responsive disease to really anything else have responses just by infusing these cells, and that many of these patients have durable responses that have now lasted over 5 years. So it's a very, but still, even though there are now hundreds of patients who've received these therapies, I want to emphasize that it still is very early in the development of these treatments. We're still trying to understand who are the best candidates for this therapy, and this treatment is not without its side effects. One of the toxicities, whenever you're really good at destroying tumor, there's a thing called tumor lysis syndrome, where the tumor can really pop aggressively and throw the pieces or the innards of these tumor cells into your bloodstream. It's actually something you sort of want. Of course, you want to destroy the tumor, but if you get a lot of potassium and a lot of uric acid put into the bloodstream, that can be dangerous. So you have to watch these patients very closely, particularly early on when they receive their therapy. There's another thing, because these cells are so good at indiscriminately destroying lymphocytes, B cells and plasma cells are the cells that make antibodies to fight infection, and so some of these people will have a very long-term low levels of antibodies, and so sometimes they need transfusions of antibodies in order to keep them from getting bad infections. And then finally, there's a new side effect when it comes to the infusion of these cells, and the term is called cytokine release syndrome. So there, and what it basically is the release of inflammatory chemicals in the patient as these cells are popping and as the CAR cells are proliferating. That leads to almost like an infection-like syndrome where people can have high fevers and shaking chills and low blood pressure and oxygen things and confusion. And it's driven by the production of these inflammatory cytokines. Fortunately, we understand it and we have the antidote for it. And the name of the antidote is Tocilizumab, which is a drug that blocks the inflammatory chemicals from causing a lot of side effects. And the vast majority of people, if they start developing this cytokine release syndrome, will respond to treatment with that. And as I've said, particularly in younger patients with acute lymphocytic leukemia, we've seen tremendous responses. If you look at slide 26, 93% of the patients who had relapsed and refractory acute lymphocytic leukemia went into remission, and people who went into complete remission, the majority of those people are long-term doing very well. Well, so that's in B-cell malignancies. Now, multiple myeloma is a B-cell malignancy, and you can see on slide 27, as a B-cell matures, it almost always has the CD19, this target of the CD19 Chimeric CAR cell on its surface. But once the cells become very mature, and a plasma cell is the most mature B cell, it tends to lose that CD19. So maybe CD19-directed CARs are not the ideal cellular therapy for myeloma. But we had a hypothesis. Our hypothesis, and this is seen on slide 28 and 29 and 30, was that that plasma cells come from lymphocytes, come from B cells. And so that even though most of the myeloma cells are going to be CD19 negative, there will be a subset, and perhaps this is a subset of myeloma cells that are the set of myeloma cells that are the precursors, the mothers to the abnormal plasma cells. And they would be CD19 positive because they come from, they're the ones that produce these plasma cells. And so that if you could combine some chemotherapy like high-dose melphalan and an autologous stem cell transplant, and follow it with the infusion of these CD19-directed CAR cells or cellular cells, you would be able to zap most of the mature plasma cells with the high-dose melphalan and then kill off the mother cells with the CAR cells and maybe lead to long-term remissions. So what we did was we only had the ability to treat a very small group of patients, just 10 patients. So we designed a study on slide 32 to try to test whether, just to see if there's any evidence that this hypothesis might actually be helpful. And so what we did was we took patients who had really relapsed and had a very heavily pretreated multiple myeloma. And all of these patients had a prior high-dose melphalan and an autologous stem cell transplant, and they did not have a great response to that initial transplant. They all had less than a year's worth of remission after their first transplant. In fact, most of these patients had even, maybe less than 6 months of a remission. And then they could get whatever treatment that was appropriate for them. And then maybe 4 or 5 years later, if none of the other treatments were working that well, we would then do a second autologous stem cell transplant. And we know that when people get a second autologous transplant, though maybe 50-60% of those patients will respond nicely, the likelihood of a long remission or a longer remission than their first remission is very low. In fact, in our personal experience, we've never had a patient who had a longer second remission after a transplant than the first remission after a transplant. And so we wanted to see if we would create second remissions that were longer if we infused these cells. And so to be eligible for these studies, the patients had to have had a short duration of remission after their first transplant. This is on slide 33, and they could have any other treatment that was appropriate, and then we had to be able to collect T cells from them, and they had to still have some extra stem cells stored away so they could have a stem cell transplant. And so we treated 10 patients, and what we found that there was no significant side effect to the infusion of these cells after an autologous stem cell transplant. And in fact, we had very little of that cytokine release syndrome, probably because after the high-dose melphalan, the patients didn't have that much tumor, and we were able to manufacture these cells, take out the T cells, and create T cells for basically every patient who we enrolled on the trial except one. One person had difficulty getting their cells. And on slide 35, I'm going to give you the example, and this is the woman who was published. I have learned that it's far more prestigious to publish a paper in Parade magazine than to publish a paper in the New England Journal of Medicine, but this is the woman who was in the Parade magazine on slide 35. She's a 48-year-old woman, and she had an IgA kappa multiple myeloma. And when she had her first transplant 5 years prior to the therapy, her duration of remission only lasted about 6 months. And in fact, she had 10 prior therapies or lines of therapy over the next 5 years, including all the treatments that you would think of: lenalidomide, pomalidomide, bortezomib, carfilzomib, Verinostat, even Elotuzumab, which at that time was an experimental medicine, and cyclophosphamide. And she never went into complete remission, and her responses were relatively minimal to all of these therapies. And then we enrolled her on the trial. And I do have a picture on slide 36 of the group when she's getting her treatment. Unfortunately, I'm the one who needs the liposuction there on the left. But what she got was high-dose melphalan, an autologous stem cell transplant, and then infusion of these T cells. And the results were very impressive, that despite the fact that she had never gone into remission even with her first transplant, and in fact, despite the fact that we gave her a lower dose of high-dose melphalan than she got the first time that she had the transplant, after the infusion of the cellular therapy, she went into a complete remission, so a deeper remission than she's ever had, and it was what we call MRD negative. By all the techniques that we could figure, there was no evidence of any myeloma in her bone marrow. And this remission lasted for 15 months, even though her remission after her first transplant lasted for only 6 months, and was not even completely in remission. And with bone marrow biopsies and with all the tests, we could not find any evidence of any disease. And if you look on slide 40, and as I say, against medical advice, she went skiing about 6 months after this treatment because she was feeling so well. I did tell her to drink lots of fluids and not lift anything. And if you look on slide 41, we've had other patients, but only about 3 of the 10 patients who were on this trial had remissions that were as deep as hers and were longer than the remissions that. So this approach, though promising, was not the answer for everybody. So how do we make this a more generalizable therapy for patients with myeloma? Well, number one, the patients who we treated on this study, since it was the first group of patients to ever be treated with this approach, were very relapsed and refractory. Look, she had 10 prior lines of therapy, and I think the average person had something like 5 to 6 prior lines of therapy. So perhaps if we use this earlier in the course of the disease, take patients who are in their first line of therapy, but maybe have a higher risk of progression than the average person, then maybe infuse the cells earlier. And in fact, we have a clinical trial that's going on right now that's doing that. Patients who have biologically high-risk disease, we're giving them a stem cell transplant and infusing the cells. Perhaps there's better ways of engineering these cells so that the cells will persist longer and live in the patients longer. Or perhaps we need to give a higher dose of these cells, or maybe serial infusions. One of the very cool things that, another cool technology that has come out of molecular biology is what they call a genetic is now genetic editing. They call it gene editing. And you might have heard about the CRISPR technology, where you can actually, so in addition to what we've done, which is to insert a gene into a cell, you can actually take out genes. And maybe there are certain aspects of a T cell that cause those cells to die more quickly. And if you could engineer out of the cell those aspects, then maybe these cells will be more active. Dr. Abenar talked about the PD-1 inhibitors and the checkpoint inhibitors, and which basically stimulate these immune cells. So maybe the addition of those medicines to these CARs will increase their potency and increase their activity. And then as he spoke about, I've been emphasizing the CD19-directed T cell. But most plasma cells don't have CD19 on their surface, but the vast majority of myeloma cells have this BCMA, the B-cell maturation antigen, on their surface. And so the guys at the National Cancer Institute, as well as ourselves, have been studying CARs that are designed to attack this BCMA. And in fact, on slide 46 and 45, you can see the study design and some of the results infusing these BCMA-directed CAR T cells. The nice thing about this approach is it has not been using autologous stem cell transplant. In fact, in our study, we've been giving patients who don't receive any chemotherapy or any other therapy prior to it, just the infusion of these CAR cells directed against BCMA. And it's very early results. We've literally treated less than 10 patients, but we've had patients who've had beautiful, amazing responses, similar to the patient who we treated with anti-CD19 directed cells. Even though they only received the cells without a stem cell transplant. And there were some nice results that were also shown by the guys at the NIH. So the future is to perhaps use cocktails of these CAR cells, use these cells with other therapies and other immunotherapies as well as other chemotherapies. So I think that the future of immunotherapy for patients with myeloma is very bright, and certainly that's the major area of investigation right now. And it's really utilizing all of these potential immunotherapies, from the monoclonal antibodies that are directly attacking and trying to mobilize a person's innate immune system, to checkpoint inhibitors that are stimulating the normal immune cells to be more anti-myeloma, and then potentially engineering the person's own T cells to attack the myeloma cells. So I think it's an exciting time for this area. I think it's a very rewarding time for the physicians and investigators in this field, and it's certainly a very hopeful time for all of our patients with this disease. So with that, I'd like to thank you for your attention, and I think we'll be happy to answer the questions that you have.
And your first question comes from the line of Nicholas.
Yes, doctor. I was wondering, in 2015, I was diagnosed with light chain disease and was given chemo, and they gave me Velcade. And the Velcade gave me bad neuropathy in my feet, and the doctor changed it. And that was down in Florida. I have recently moved up to Cincinnati, Ohio, and I am a veteran. And I went, they did their blood tests, and they told me that I had multiple myeloma. Now, is this normal for this to change like this? How should it be treated? They're not giving me any drugs or anything for it. Do you have an answer for that, please, sir?
So let me take this. So obviously this, our discussion tonight is about immunotherapy, but, light chain multiple myeloma or spectrum disease probably was the same. The question if this is a relapse and is it causing you symptoms, is it damaging the kidneys, causing anemia or causing bone disease? If there is a symptomatic relapse, the patient needs to be treated. So I think I advise you to seek a myeloma specialist in your area. So I have a question for Dr. Stadmauer. How about the cytokine release? You said in your hands you haven't been seeing a lot of that. Is that common in the other experiences that you heard about?
So what I said was that in the patients who were on the clinical trial of where we did the high dose melphalan, the autologous stem cell transplant, and then infused the cells, we saw a very low level of cytokine release. I think primarily because the tumor burden at the time of the infusion of the cells was actually relatively low. However, in the preliminary experience with the BCMA-directed CARs, which remember is given either without any prior chemotherapy, or with just some mild lymphodepleting chemotherapy. In that experience, we're actually seeing cytokine release at a similar level as we see when we treat acute lymphocytic leukemia or chronic lymphocytic leukemia. So just to remind us, that cytokine release syndrome is not a very comfortable circumstance. You have fevers and you have aches, and we routinely hospitalize people during this time, and then frequently require anti-cytokine therapy. Nevertheless, fortunately, the vast majority of patients who have experienced this syndrome are recovering from it, and perhaps even the experience of cytokine release predicts a higher chance of a response to therapy.
So my question to you, was there any death related to the cytokine release syndrome?
There was no, in our original study, there was no one who had mortality. Now again, we're talking about our myeloma experience, which is literally about 20 patients. No mortality from cytokine release, and but the BCMA directed therapy is still early in its development.
So, and I think you brought a very important question, is that if you turn off the cytokine release syndrome, you may see less benefit from the CAR T cells?
As of this moment, though it seems that maybe the presence or development of a cytokine release syndrome in the course of the therapy may suggest a higher chance of response. There is no evidence at this time that if you turn off the cytokine release, that is detrimental to the outcome. So no, as of this moment, we don't have any qualms about treating it. In fact, we feel strongly about treating it, particularly when. But we also, the big debate in the field is, should patients be prophylactically treated with anti-cytokine therapies to try to prevent it from ever happening? And as of this moment, until we have more information, we are not doing that, given the possibility that some cytokine release may be helpful.
Okay. Any questions?
Your next line comes from the line of Dana Holm.
Hi, good evening, doctors. Thanks so very much. Listening intently, and after listening to Dr. Stoudemire's the complexity of the CAR T cell therapies, I'm wondering how can we as patients really feel hopeful about the drugs that are on the table now available to us, including the monoclonal antibodies and the checkpoint inhibitors. Would combining monoclonal antibody and checkpoint inhibitor make sense for a newly diagnosed myeloma patient to kind of bridge the gap until this emerging therapy becomes more available? I hope that question made sense.
No, it makes tremendous sense, and I'll let Rafat probably give most of the brunt of the answer, but what I would say is this. I mean, the CAR T cells still, in my opinion, are somewhat science fiction, though it's science fact right now, and we're treating people, but it certainly is not ready for prime time. The history of the therapies for myeloma, though, are so promising and are so inspirational. I mean, and so incremental that we started off with just oral steroids and oral alkylating agents, and then every time we develop a new class of medicine, we learn how to combine it with the old therapies, and we usually start off treating the very heavily pretreated and sick patients, and then when we learn how to use it and how best to keep the side effects, we then move it earlier and earlier into therapy, and the chance of responses and the durability of responses and the survival and the life of people with myeloma has improved so much over the last 5 years that even if it takes a little while for these cellular therapies to really come on board, I think the developments that we've had with these monoclonal antibodies, with the checkpoint inhibitors, when combined with all the therapies that we already have, I mean, just the current treatment of myeloma is very positive, very bright, and people should be very optimistic when they have these diseases.
Thank you, Dr. Stoudemire. And any other comments?
No, I mean, I agree. I think the most important thing is that we keep the myeloma under control, use the best combination therapy to provide the deepest response. I mean, I think, getting rid of myeloma is a good thing, yeah? And so the best drug should be used for the patient. I think, myeloma is quite a heterogeneous disease, and we need to really utilize myeloma specialists, understand myeloma to help guide the therapy to get the best response. And, hopefully we start getting more patients into what we call minimal residual disease, where you can look in 1 in a million cells in the bone marrow and you don't find myeloma. That's a good thing. So let's use the best combination as soon as possible. Next question.
Your next question comes from the line of Barbara.
Yes, I heard you say, I believe, with the cellular immune therapy that the patient had to have a stem cell sample remaining. Is that correct? Did I hear you correctly? Because if one has been down this long trail and three stem cell transplants, you wouldn't have any left in most cases, I would think.
Yeah, no, that was for the study where we included a stem cell transplant into the therapy with the cellular therapy. But no, the current studies where we are not also having a stem cell transplant, they do not require stored away backup stem cells.
Okay, thank you.
Next.
Your next question comes from the line of Betty.
Yes, hi. Thank you so much for all your work and your presentation. Prior to being diagnosed with multiple myeloma, in 2008, I had autoimmune hepatitis. And I'm very interested, obviously, in all the immunotherapies that are being studied, but it does concern me that in my particular case, it isn't clear if my immune system was working overtime or undertime, and whether getting involved with immunotherapy would be contrary because of my history with having an autoimmune disease of that time. What are your thoughts?
I think it's an excellent question. I'm glad you brought it up because when we use these immunostimulating therapies such as cellular therapies and the checkpoint inhibitors, there is a possibility of exacerbating autoimmune disorders. And in fact, it is one currently of our contraindications to including people on these trials. Anybody who has clearly an active autoimmune disease, we are very hesitant to enroll on some of these immunotherapy trials. So it's a very good point, and as of this moment, it is something that we have to be very cautious about.
Well, just to finish, it is not active. As soon as they took me off the drug for the autoimmune hepatitis to put me on Revlimid and Dex, my autoimmune hepatitis went away.
Yeah.
Good.
Well,
do you have another question?
No, thank you.
Anybody else?
Your next question comes from the line of Stephen.
Hi there, Dr. Stoudemire. I have a question for you. Are you currently enrolling anyone for your trials at the moment?
Yes, we do have an active trial for patients with high-risk multiple myeloma getting their initial therapy. So as part of their first autologous stem cell transplant, infusing those CD19-directed cells. And we also have an active protocol for more advanced patients getting that anti-BCMA trial. Though that study is sort of full for the moment, but probably in early 2017 will be open again for accrual.
Okay, thanks very much.
Your next question comes from the line of Margaret.
Good evening, doctors. Dr. Stoudemire, you are very close to a place that's very close to my heart, CHOP. My son was treated there in 1978 and 1979 for non-Hodgkin's lymphoma. So I was excited to see that there was so much going on over at HUP. But I do have a question about myself. I was on August 14th of last year, after a lot of doctors telling me there was nothing wrong with me, I was diagnosed. My hemoglobin was down to 5, and I was rushed in for 4 pints of blood, at which point they found the multiple myeloma. I immediately began treatment through UPMC out here in Pittsburgh and had an excellent response to the Revlimid, the Velcade, Dexamethasone, and then went for my stem cell transplant on February 24th. 22nd, I had my 2 days of Malflin. 24th was my transplant. I did what they said was remarkably well. At the time of my apheresis, they told me that I was the stem cell queen of Hillman Cancer Center because I produced 24 million stem cells. At the time, I said, well, I went to Catholic school. I always was an overachiever. But anyway, I had 12 million given to me at the time of my transplant. And I left there feeling very optimistic until 3 weeks ago, when I received a call from my oncologist telling me that even though my CBC differential side of my blood, everything was exactly where it should be, my white blood cells, my hemoglobin, my neutrophils were all great, I spiked a 0.6 abnormal protein on my myeloma side. Now, I am not as versed as some of the people who have been phoning in about the light chains and everything, but they immediately started me on an increased dose of Revlimid. I had been on 10 milligram after my transplant. They took me back up to 25, started me also on a new drug that I've had 3 cycles of called Cripolis, and also put me back on the Dexamethasone. But the one thing, doctor, that I really need that's been most upsetting to me on top of the phone call I received is the fact that they keep using the word to me that I have an aggressive form of myeloma. I know that there's smoldering, but I don't understand how I can overachieve in the stem cell production, have excellent response, and the word aggressive is almost eating at my brain because I feel like I'm going into World War III with a slingshot at this point. I'm trying to keep my hopes up, but I don't understand that word. Can either one of you fine doctors explain it to me? They keep using this word at me that, well, you know, you do have the aggressive form, and it's like, well, how many forms of this are there?
Yeah. So I think the hour is, I guess, almost over, so we've tried to wrap things up here quickly. Okay. So what I would like to say is that, yes, I mean, we have different form of myeloma, and sometimes, you know, having residual disease is not the end of the world. We know that the myeloma is aggressive by the rate of relapse, by the cytogenetics at diagnosis, and I think it's very important that for each patient who get diagnosed with multiple myeloma is to see somebody who really specializes in myeloma. There are a lot of good oncologists in America, but myeloma is 1% of all cancer, so not everybody is going to develop expertise in multiple myeloma. Today, I saw a 27 patient with myeloma, so it's you know, that's what I do, and there's you know, Ed does the same thing. He probably saw 30 patients today with myeloma. So you want somebody who has seen tons of myeloma so that can help you. So when you call call the hotline at the International Myeloma Foundation. They can try to direct you to a myeloma specialist close by so you can get the best evaluation. So what I think, the bottom line today you heard is that immunotherapy is very promising. CAR T cells are, also promising, but you heard Dr. Ed Stadmeyer saying that this is actually almost like a science fiction that is trying to come into the clinic and is still in a clinical trial. It's not ready for, what we call, standard therapy. We need to optimize the target to know which target to attack, when to give these T cells. Do we give it after relapse? Do we give it early after transplant? In what setting to give? So we are still learning how to use these engineered T cells. We're still learning how to use the checkpoint inhibitor. So I hope that we'll have more clinical trials available to more patients. So hopefully in a couple of years or maybe in a year, we will learn what is the best immunotherapy for patients so we can cure some patient and hopefully every patient. So with that, I think, Robin, you can take it.
Okay, so thank you both Drs. Abenauer and Stadmeyer for taking this time this evening to help us better understand the importance, the complexity, and the promise of immune therapies, and specifically CAR T-cell therapy in clinical trials. I totally understand we're all still learning on this, and the future is always bright because of great doctors like you and the research that continues to happen. So a few reminders for everyone. The IMF website is a wealth of information. Please go to it frequently at www.myeloma.org. And also, thanks, Dr. Abenauer, for reminding everyone of the IMF's great info line, and that number is 1-800-452-2873. Missy, Judy, and Paul are available to take your calls Monday through Friday from 9 a.m. to 5 p.m. Pacific. And I want to thank once again our presenters tonight, of course, Dr. Abenauer and Stadmeyer, and our sponsors, Amgen, Celgene, Janssen, and Takeda. And most importantly, thanks to all of you on the call tonight. I hope this was helpful and hopeful to you, and have a wonderful evening. Thank you.